Hey, it's Rob Fitzgerald again. Thanks for tuning in. I would say this is another quick hits in lab medicine section, but we're talking about drugs of abuse, so that might not be appropriate. We'll also talk about a couple of therapeutic drugs that cause toxicity. And I used to work in the medical examiner's office, and tricyclic antidepressants were probably the most common cause of overdoses in prescribed drugs. They have a bunch of different effects and essentially all lead to arrhythmias. And so patients typically aren't monitored for concentrations of tricyclics because concentrations in blood really don't correlate that well, whereas overdoses can be monitored by EKG changes, and so looking again for arrhythmias. Patients die from cardiac arrest. SSRIs, serotonin reuptake inhibitors, generally replace this group of compounds, but they still are used, and we still do see toxicity from tricyclics. They're used primarily for depression, but they also have found new uses in pain management. So we're starting to understand a little bit more about pain management, and different drugs besides opiates are being used effectively. Some anticonvulsants, for example, as well as the antidepressants. Benzodiazepines, as a class, they're frequently cause mild toxicity, but essentially very rarely cause fatal overdoses. They're anxiolytics, sedatives, and hypnotics, depending on the drug and the dose. As I said, we encounter these frequently. They're generally not toxic unless they're combined with something else like alcohol, which is also a CNS depressant. There is a very good antidote, flumazenil. It's a competitive receptor at the benzodiazepine. It's a competitive receptor antagonist at the benzodiazepine receptor. That was kind of a mouthful. It is quite effective. It is used in overdoses, but the medical toxicologists are careful with that because in certain cases it can also precipitate seizures. So I guess that would be a case if they've co-ingested, and commonly people that are suicidal will co-ingest different meds. Opiates, probably, from a drugs of abuse perspective, are most commonly fatal drug of abuse, particularly with our fentanyl epidemic that we're currently in. The triad is coma, decreased respirations, and pinpoint pupils. That's the telltale sign of an opiate overdose. And, these patients are going to be given the antidote naloxone. It's an amazingly effective antagonist. It's a competitive antagonist at the receptor. Patients can be almost dead, and you give them naloxone, and they wake up and they're ready to go. And we need to think about half-lives and what drugs they took, because the naloxone might wear off faster than the opiate that they took. So they give it, serially, and if they don't get improvement, then they're thinking about other alternative diagnoses. So this class includes morphine, codeine, hydrocodone, hydromorphone, oxycodone, the fentanyls, so a variety of things that are acting at the mu receptor, the mu opiate receptor. And when you're doing drug screens, different drug screens react differently with all of these compounds. So, most what they call, quote, opiate drug screens pick up morphine and codeine. They don't. They usually have a little bit of cross-reactivity with hydrocodone, but they don't pick up other structurally unrelated compounds like oxycodone and fentanyl and things like that. Heroin is the street drug. It is diacetylmorphine. Call my laser pointer here. So morphine has hydroxyl groups here and a hydroxyl group here. It's acetylated, so it will bypass the blood-brain barrier better. Once it crosses the blood-brain barrier, it's converted into acetylmorphine, and then finally to morphine. Morphine is what's binding to the mu opiate receptor. Morphine is also a metabolite of codeine, And so if you find morphine in a urine specimen, it could have come from administration of morphine itself. It could have also come from codeine, and it also could have come from heroin. And so really the only way to know if someone took heroin, most drug screens are going to also be looking for acetylmorphine. And if it reports out as acetylmorphine, it came from heroin. So a finding of acetylmorphine helps us figure out that it was a street drug, versus if you only find morphine, you don't really know where it came from. Heroin and acetylmorphine both have very short half-lives, so may be detectable up to, in the setting of at least acetylmorphine, maybe 24 hours, but rapidly clear. So just because you don't find acetylmorphine doesn't mean that they didn't take heroin. Cocaine is snorted, it's smoked, it's injected, it's also taken orally, so a variety of different ways to administer cocaine. It blocks reuptake of norepinephrine, so it has an adrenergic effect because of that. It blocks sodium channels, so fast sodium channels, so it's a good local anesthetic. So it's used therapeutically in nasopharyngeal surgeries because it's both a vasoconstrictor, it lessens the bleeding, and it's also a local anesthetic. Toxicity is due to the excess adrenergic effect, so beta-1 and alpha-1 activation. Patients become tolerant to the stimulant effects, but not to the local anesthetic effects. So they keep taking bigger and bigger doses and typically get cardiac toxicity. It's usually detected as an inactive metabolite. So cocaine has a short half-life of around an hour, 45 minutes to an hour and a half. Whereas its metabolite, benzoylecgonine, has a half-life of about 7 hours, and so we pick that up as our long-term monitor in urine specimens. So that's the structure of cocaine. It is demethylated to form benzoylecgonine, half-life of about an hour, half-life of about 7 hours, so we can pick up benzoylecgonine longer in a urine specimen. Ecgonine methyl ester is a metabolite typically not measured. Interesting, when people drink and take cocaine, there's a transesterification that happens in the liver. And so essentially this methyl group is replaced with the ethyl group from ethanol, and we have coca-ethylene. So instead of having a methyl group here, we have an ethyl group here. And that's important to monitor in overdoses in like the medical examiner's office. They're going to measure both concentrations of cocaine and coca-ethylene, because coca-ethylene also crosses the blood-brain barrier and binds to similar receptors. So it adds to the effect of cocaine. Amphetamines, San Diego was known as the meth capital of the world because of how much methamphetamine we have around. It's smoked, it's injected, it's also taken orally. It's like cocaine, it's going to cause an adrenergic effect. So we're going to have excess adrenergic stimulation. And toxicity is going to be hypertension, arrhythmias, agitation, hyperthermia, paranoia, all related to its adrenergic effects. Unlike cocaine, typically if someone who's taking cocaine makes it to the hospital, they're going to survive because the drug is metabolizing fast enough. Amphetamines have half-lives of about 5 to 7 hours, so they can die even hours after shooting up. Treatment is essentially supportive. Barbiturates used to be a very common cause of overdoses. Since benzodiazepines have largely replaced them, we don't see them as much. They're sedative or hypnotics, depending on the drug and the dose. The ones that have shorter half-lives are typically more potent. And drug screens are going to tell you barbiturates are present. They're not going to tell you which barbiturate is present unless you do something like chromatography and mass spectrometry to identify specific barbiturates, which are important to know because of the potency based on the half-lives. And as we said, benzodiazepines largely replace these for anxiolytic effects. They're still used as anticonvulsants, and we do therapeutic drug monitoring on them for that reason. They're central nervous system depressants, so like the benzodiazepines and other CNS depressants, deaths are due to respiratory arrest. Marijuana is very commonly found in urine specimens. People don't die from marijuana, not directly anyhow. Really, intoxications, there are some psychoses that are due to marijuana, but they don't have typically what we associate with acute toxicity like cocaine or amphetamines. Urine drug screens pick up the carboxylic acid, and people say, how long do they stay positive? A naive user typically stays positive for a couple of days, maybe 5 days, but usually it's a couple of days. Chronic users can be positive for weeks. So we're picking up an inactive metabolite in a urine specimen, and they can last for weeks and maybe even longer than that, depending on how sensitive your detection is. PHENCYCLIDINE is a dissociative anesthetic. It was regionalized. We see it across the country now still. It's much less prevalent than any of the other drugs we encounter. And when we're thinking about screening, we need to think about the prevalence and the positive predictive value of a screening test. So even though it's a very good immunoassay, the positive predictive value is poor. In some cases, it's 0% because the prevalence is 0%. Here in San Diego, at UCSD, the positive predictive value of a phencyclidine screen is about 30%. Even though the specificity of this test is quite good, the prevalence is just so low that positive predictive values are not very good. These patients do become very combative, and so they get major tranquilizers to try to calm them down. And as I said, the positive predictive value of the immunoassay screen is not very good, so they should be confirmed by a second technique like mass spectrometry. And if you confirm it by mass spectrometry, then you have a confirmed positive result, and you know that that patient took phencyclidine. Hallucinogens, like marijuana, they don't cause frank toxicity, but they cause behavioral toxicity. People think they can fly and they jump out of a window. And so that's not a direct toxicity of the LSD, but it's what LSD made them do. So most drug screens are not going to pick up hallucinogens. If you're looking for LSD or mescaline or something like that, you have to have a very specific order for that. So you have to have some reason to believe that your patient was taking a hallucinogen. So your normal tox screens are not going to pick these up. As we said, they're generally not frankly toxic, but behavioral toxicity. Here's a case. LSD is really potent, micrograms. So most drugs are, milligrams, but a couple of micrograms of LSD causes people to have hallucinations. And so this is a case where if you submit the pills and powders, it might be helpful to the lab to identify what the person was taking. Just because the concentrations there are going to be so much higher than if they took it and we're now looking at a urine specimen that was taken 24 hours after they ingested the drug. Designer drugs have become a bigger and bigger problem. In our laboratory, we found designer amphetamines, we found designer opiates, we found designer THC analogs. So, basically every class of compounds are subject to designer drugs. Designer drugs really are designed to get people high and bypass DEA regs. So that's what I think about when I think about designer drugs. So a whole host of fentanyl analogs, MDA, MDMA, we would say those were designer drugs. The fentanyl analogs have caused a lot of problems regionally and in certain sporadic cases where a designer fentanyl is introduced to a heroin using population. They're not used to the potency, and you get several deaths due to these compounds. Fentanyl is responsive to naloxone, so there are good antidotes. Another sort of tragic one was MPTP. They were trying to design the reverse ester of meperidine, Demerol, And when they did that, they formed some elimination reaction, which causes the formation of this very toxic compound. That's now a model for Parkinson's disease. Right now, we are dealing with spice. So these are synthetic THC analogs. People don't die of THC, but they can die from these THC receptor agonists that are quite potent. Bath salts are synthetic cathinones. They're related to amphetamines, and they're also there's hundreds of them. And so it's difficult for a toxicology lab to keep up with that. And so the designer drugs will continue to be a problem that both analytically and clinically are hard to pick up. So thanks for tuning in, and hopefully we'll see you again on another quick hit in lab medicine.